Okay. Hello, everyone, our dear friend and our lovely audience in ICC. No matter where you are from, in Asia, in America, and in Europe, thank you for your patience tonight with us. Today, we are so happy to have our our 20, the ICC webinar online with all of you. Today, we have a very special speaker, Professor Chien-Tzung Chen, and will give us a very special topic with us. And we have a very special moderator as well, Professor Howard Chen. So in the first beginning, I would like to invite Professor Howard Chen. He will give us a very kind and a very warm greeting and introduction for our Professor C.T. Chen. Please, Professor Howard.
Thank you, Dr. Zhou. Hi, everyone, all the good friends of ICC. I'm Dr. Chen, and it's really my honor to introduce our speaker, Professor C.T. Chen, today. Professor Chen completed his plastic surgery residency at Chang Memorial Hospital in Linkou, Taiwan, and pursued a clinical and research fellow in plastic surgery from 1997 to 1998 at the University of Texas Southwestern Medical School in Dallas, USA. He became chairman of the Division of Trauma Plastic Surgery in Chang Memorial Hospital in year 2007, and he has been superintendent of Chang Memorial Hospital at Keelung between 2016 to 20. Now he is the executive deputy superintendent of Chang Memorial Hospital at Linkou. He has been the president of the Taiwan Craniofacial Association since year 2013 and president of Taiwan Society of Plastic Surgery since 2016 and the chairman of the Sixth World Association Plastic Surgery China Descent in year 2018. Professor Chen also authored more than 120 outstanding publications and book chapters. He has served or continued to serve on the editorial board of several journals, including Plastic Reconstructive Surgery, Asian Journal of Surgery, and the International Journal of Craniofacial Trauma. His topic today is evolution on orbital reconstruction. Let's welcome Professor C.T. Chen.
Thank you, Mr. Chairman, Professor Chen, and Professor Zhou. It's really my great honor and pleasure to share my experience on the evolution of the orbital reconstruction in the past 28 years old. Regarding the orbital fracture, we now know this is increasing the frequencies. In our series, is almost accompanied about the 70%. They isolate the orbital fractures will be less, but most of them combine medial wall and floor fractures. The most common associated facial fracture is zygomatic fractures. However, Dr. Byrne has published the PR is saying that the pure orbital fractures should be emphasized. He found there's isolate medial wall fractures account 55% in his patient series. So we should know about the associated orbital medial wall fractures. So the mechanism of the fractures most caused by the trauma or spore injury. Sometimes some kind of like a yoga, the spore may also injure the glove, resulting in blowout fracture of the orbital flow. So the preoperative evaluation, I think that's quite important, is because we know the patient might have a severe occlusion or the disorder after the fractures is account almost 70%. So we need early ophthalmologist consultations. They have to evaluate the pupillary functions, visual acuity, extraocular muscle movement, and they evaluate such the patient had endoscopic or exosomes. Nowadays, the 5 solutions, the CT scan will be the standard examination procedures because it can provide very high degree of accuracy It can provide also the several view, including coronal axial and the sagittal reformat. We have such a kind of the detailed information there, so we can decide how to approach the fractures the area. So preoperative examinations regarding the eye movement also important. We can using the odd finger to instruct the patients move the four directions, and sometimes under the local anesthesia we can perform the force touching test. In that way, you can know where the orbital tissue has been entrapped in the orbital trapezoidal fractures. This is the example. The patient, like this patient, she had a left side orbital brow fractures. We can see the patient had a left eye and a sinus impedance, and also CT scans can show the medial and also the floor fractures. And also we can using the NAGO the measurement to the difference around the both sides. So we can see the base view for the patient to see whether the patient had an sinus is a warm eye view. So we know the orbital reconstruction is really a most challenging task in the facial fractures repair, because there is many vital structure inside the orbit. Sometimes we even experienced surgeons still result in the unpredictable result. So improper management will result in not only the functional but also the aesthetic impairment. So the goal of our surgical repair was to restore the ocular motility, prevent further orbital content herniations, restore traumatized, or avoid late endosomas if the patient present. Regarding the surgical intention, this has been proposed by the Dr. Burstein. He found that the patient had acute endosomas more than 2 millimeter. We found the orbital tissue incarceration with globe retractions, persistent diplopia more than 2 weeks, with evidence of the tissue entrapment or large orbital flow fractures more than 50% of the flow. That's all the indications. Recently, we found that there is advances in the treatment of orbital fractures because we know the complex anatomy of the orbit and also mechanism in the detail, and increasing the diagnostic tool such as the CT scan. CT scan right now become the standard examination tool for all the facial trauma. And now we also have many numerous biomaterial for the orbital reconstructions. And also the surgical approach is improved nowadays. And recently, computer-aided surgery become more and more popular. We can use that computer to assist preoperative simulations, 3D printing, modeling, or 3D printing material. And also you can use in the intraoperative control, such as the intraoperative CT scan, navigations. They can provide you real-time 3-dimensional image and view the procedures in progress. Regarding the surgical anatomy, we look at the orbital medial wall. They have the 3 important structures inside. Anterior is more foramen, posterior foramen, and optic nerve. So we know that the optic nerve foramen is around the 3 to 12 millimeters next to the posterior foramen. These 3 structures connect from the upper border of the medial wall. So look at the medial. So the medial is the more fragile, and below is the orbital flow. In between medial and the flow is orbital buttress. The orbital buttress is also very important. Once the orbital buttress has been fractures into the community type, they will result in very huge endosomas. And also look at the anatomy of regarding the flow. We can see from anterior to posterior is concave to convex upward inclination around the 30-degree angle. From the lateral to the medial, it contains a superior inclination approximately 45 degrees to create the inferior medial bulge. That's what we so-called orbital buttress. There are several grafts can be used for the orbital reconstructions. One is autogenous bone graft. They have several types, cavarian iliac or regraft, or synthetic implant, including the titanium mesh, maple, super mesh, silicone sheets. Nowadays, the silicone sheet has been abandoned for the further orbital reconstruction because he produced very late complications. Regarding autogenous bone graft, the most commonly used probably the cavarian bone. If the patient had coronary incision to approach the frontal supraoperative area, we can use the same incision to approach to harvest cavarian bone grafts. Otherwise, you can use the other like the iliac or the rib bone graft. However, both of them has a more higher resorption rate. The others for the small bone, you can use anterior massive wall or lingual cortex or coronary process. Next example, the patients have a very severe frontal orbital roof orbital ring fractures. After reduction of the supraorbital ring, we will find the orbital roof fracture. So we can harvest cavarian bone graft and insert the cavarian bone graft at the same incision to reconstructing the orbital roof. This is possibly citizen the result showing here. We can see the bone graft on the floor and of the roof. The others with regraft, such as these patients had a very severe facial trauma, orbital and ligament community fractures. We can see the flow out on the floor and also lateral wall. So we harvest the regraft at the same time, same approach, and using the regraft for the orbital ring, lateral wall, and also the flow, lateral orbital buttress. Then this immediate possibility result, we can see the flow had a regraft and the patient had a symmetry eyeball projections. It's only one time immediate reconstruction, so we can get the such a good result. And regarding the immediate reconstructions for the complex orbital fractures, Antonio should compare the cartilage graft versus bone graft. They indicate the cartilage graft is too flexible, providing inadequate support. So only indicate in small defect in selected patient. Regarding alloplastic material, nowadays become more and more popular, especially for the young surgeon. They would like to using the alloplastic implant because more convenient and no need to the donor sign morbidity. They can divide it into two categories. One is non-resorbable, the other is resorbable. Nowadays, most commonly used is non-resorbable alloplastic, such as a metallic mesh or hydroxyapatite or porous polyethylene. Metallic mesh has been used for many years. They had the advantage to provide thin, easy contouring, stabilization, and stable maintenance. However, still have some complication, infection, and 3.3% need to be removed after infections. How about the disadvantage? If the risk of the extrusion, sometimes difficult to remove because soft tissue incarcerate into the titanium mesh, because the mesh design have a small hole. Where this kind of the design will restrict the ocular muscle functions, this is no answer right now. But however, this mesh can be used combined with a bone graft at the same time for further augmentation. Look at this patient the 12 years girl has a trapezoidal fracture, has been treated outside, but still can move the right eye downwards. So we explored it, and we can find entrapped the muscle at the most posterior part. After releases, we can see a very small hole. So in this patient, we just reconstruction with titanium mesh. See, this is the result. After that, we can see the patient can have the eyeball downward movements and the symmetries eyeball projection too. The other example, the titanium mesh plate using the for the orbital flow reconstruction. This patient has been reconstructed with a silicone sheet, but inadequate, so still present anasomers. We can see from the CT scan and the preoperative one-eye view. So we remove the silicone sheets further and reconstruction with the this titanium mesh from lavenders. So we can see this post-operative scan and the symmetry eyeball projections almost 1 to 2 years old. However, still have some complication from the titanium mesh. This patient has been reconstructed with the titanium mesh before he came to our clinic 2 years ago. Then he progresses the swollen over the right eye, and we can see the a little bit exosomes. So from the CT scan, we can see the previous mesh right over here, but the infection pushed the globe upwards. So we brought this patient to operating theaters, remove the mesh, and get the infection out, remove the foreign body. Then this is post-operative appearance, the infection subside. The other complication of titanium mesh may result in the muscle impingement. This is the patient example. The patient has been reconstructed with the preformed mesh, but still present have the right side endosomes and restricted the right eye upwards and also the downwards. So look at the CT scan, we can see this mesh. The one arm almost impinged into the optic nerve, but fortunately, he did not injure the optic nerve. The visual acuity still be preserved. So we removed it and revised it, and the patient had more extraocular muscle movement upward and also the downward. The others implant is more commonly used right now is Maple. Maple has a pore size around 100 to 200 micrometers. They have a rapid vascularization because of the small holes. Where the implant can cause restriction of the equator muscle still unknown. Whether we need to associate the implant in the antibiotic solutions to prevent further infection, the answer still not complete known. But in our experience, most of the time, the optical implant of the Maple for the orbital reconstruction will not use the antibiotics, except using for the like the mandible reconstructions. However, there's some disadvantage. It's not a radio dense, so you cannot see very clearly on the post-operative CT scan. This is the Maple graft. These are the modifications. Is there has the barrier graft that indicates the one side is made by the silicone sheet on top of the Maple. So we can reconstructing, especially for the secondary cases. For these cases, you can see the blowout fractures with a hole in the floor. So you're reconstructing the barrier graft, reconstruction the flow, and also prevent the further ocular muscle adhesions. So this is a comparison of the several graft and the autogenous. So you can see the definitely autogenous graft is biocompatible, but they have a risk of resorption. So porous polyethylene and banana mesh is still can maintain the volume well, but for the secondary cases, we need more volumes. Regarding the approach, we have several, and it's being used such as a low-lead incision, transcondylar incision, supraorbital eyebrow incision, or corneal incision. There are several incisions can be used to approach different area of the orbital, such as the medial wall flow. This is the low ID, the approach. They have a subsidiary, subtarsal, infraorbital. Most commonly used would be a subsidiary. Subsidiaries, we raise the skin flap. Mostly used in the skin muscle flap to prevent further atrophy. But however, if do not really exactly execute your dissection, still can result in the postoperative atrophy. This is the subsidiary approach. For this approach, we can not only use for the flow reconstruction, but for the orbital ring, we can still insert the mini plate easily to put on the plate, compare the transcondylar incisions. But the risk of the subsidiary is the risk of the atrophy on the sclera shore. Still have some percentage. The other is inferior transcondylar approach. They can be used for the access overflow and infraorbital ring, but difficult to access the orbital medial wall. They also have the advantage that provide no visible scar, but could have a risk of the entropy. This is the example. The patient had left side the floor fractures for this 9 years old female child. We can see the CT scan. So this case, we harvest the regraft and approach from the transcondylar the incisions, then put on the regraft on the floor. This is a 2.5 years follow-up. The wound heal well, the bone heal well, the patient has a symmetry eyeball projections. But there is risk the complications such as congenital granuloma, hematoma, leukemia, the injury, or low eyelid lacerations, or entropy. This is the postoperative complications such as the entropy. So we try to using the other approach to avoid this the complication from external. So we started using the endoscope around 20 years ago. Why we need to develop the endoscope surgery? Because the patient they want the minimum incision, they want the quick recovery, no downtime, and this kind of the endoscope surgery can be widely used not only for cosmetic, but it can be used for reconstruction surgery and also for the bony framework reconstructions. So the instrument we need, just like the endoscope instrument for the laparoscope, but we use a small endoscope. We can use 2.7 millimeters endoscope for the medial wall, 4.0 for the flow reconstructions, and all the instrument is long shaft, and they have a small tip on the anterior end of the instrument, so that will help you to grasp the fracture fragment. And definitely, we need a small suction caster and the retractors too. So this is kind of the operating theaters using for the medial wall and also the flow. The first one we talking about medial transcondylar incisions. In this case, in such the approach, we can make the incision over the medial transcondylar, the usual retrocorontal area. we need the local anesthesias to make the incisions. Then we dissect the anterior portion of the medial wall under the direct visions. Then we dissect the pocket to insert the endoscope. We use a 2.7 millimeter 0-degree endoscope for dissections. So you can see that from this view, we check the orbital medially, laterally, so we can see the fractures area and see the some fragments right here, some of the orbital content. If the anterior sigmoid artery or vessel still intact, we need to calculate for the further posterior visualizations. So we can move more posterior down to the posterior sigmoid artery, which is the posterior boundary of your dissections. So we can see that all the herniating orbital tissue can be retracted into the orbital cavity. Then we can also see all the boundary on the superior medial and the inferior medial, and also the posterior side. Finally, we can using the kind of the bone graft, titanium mesh, or maple for further reconstructions. So this is our procedures. We can see the defect has been well defined, and this the contused medial rectus muscle. And then we can reconstruction with several the implant or bone graft. So the approach can be used for the various size of the medial wall fracture isolate, can use for the primary and also secondary corrections. But if the patient need for the coronal incision to approach supraoperating also the medial wall, we definitely no need such kind of the incisions. This is the example. The patient had injury, also the medial wall fracture too, had and summers. Using the similar approach, reconstructions, so you can see the possibly the CT scan and possibly one view patient had the symmetry eyeball projection, and you can see the patient maintain very well symmetry eyeball projection at the 10 years old later. The other example, the patient had presented as a left side medial wall fractures. We can define the medial wall defect very well. And this patient was reconstruction with maple. We can see the patient's 1 year's follow-up, and when he heal well, and symmetry eyeball projections. So this method provides very direct exposures feasible for any kind of the orbital wall reconstruction, provide invisible the scar. The other approach can be used that is endonasal. This being proposed by the ENT doctors. So we can choose a transnasal and resect the Woodstate's process get into the ethmoid sinus. Once get into the ethmoid sinus, we can identify the fractures, the site, and we can perform the Bob test to push the globe gently to look at the where is the herniated orbital tissue. Then we reconstruction the medial wall either with Gore-Tex or the maple implant. Our method is quite different from the others using the previously using the stick-on sheets for the reconstructions. This example, the patient presenters have the right side, the orbital medial wall fractures. So we using the same approach, and then reconstruction with maple implant. This is half years later. The patient present to us very good the eyeball projections without any complaint or complication. The other example, the patient presenters have the left side medial wall fractures. We can see that the muscle, medial rectus muscle, go into the ethmoid sinus, and we move it further reconstruction the maple implant. This is a half years follow-up. The patient had also had a good symmetry eyeball projections. This is a paper published by Dr. B. He compared the subsidiary approach and the transnasal approach. And they found both groups have a similar result, but transnasal approach have a more they need more expensive tool because we need the endoscope and the other endoscopic instrument and more skillful compared with the traditional open methods. For the large defect, you also found that there were some difficulty for reconstructions. As this is not indicated for secondary reconstruction. They need a longer time for reconstruction compared with traditional methods. Then we're talking about the endoscopic repair, the optical flow fractures. The approach we're using the buccal incision to make the entrance stomach 2 by 1.5 centimeter just below the inferior ring. Then, if the patient have the existing zygomatic fractures, we can enlarge this, then insert the endoscope for the further visualizations. So we look at the video. You can see the entrance stomy, and then we can see the herniating of optical tissue and the fractures fragment. Definitely, we need to remove the fractures fragment to avoid further impingement if we put on any kind of the implant. The posterior side is so-called posterior ledge. In this area, we can identify the posterior part. And then we also see the involved nerve just going just below or inside the maxillary sinus. This fragment has been removed for complete visualize the orbital defect, and then we can push upward over the orbital content back into the orbital cavity, and then finally the defect can be reconstruction with either the titanium mesh or the macro, depending on you can find the possible the edge for the implant placement. This is the intraoperative view. Endoscopic view, you can see the several. This is nerve herniated, the orbital content, and then reconstruction either the mesh or the macro implant. And this is the diagram showing the mesh has been fixed on the anterior part because the anterior part has had more rigid bone for you for the fixations. So that can be used for the variable size isolated flow fractures, floral fracture, or the patient combined with medial or the inferior fracture associated the zygomatic fractures. This example, the patient present has a left side, right side optical flow fracture during the car accidents. So we identify the flow, the herniating tissue has been reduced. Then we reconstruction the maple implant. This is also pretty result. We can look at the patient's 1 month and 5 years follow-up. The patient still maintain very well after reconstruction. The other case, the patient presenters have like the left side flow fracture and also the associated zygomatic fractures. After reduction of the zygomatic fractures, we can enlarge the the wall on the anterior sinus, anterior muscle wall. So after reconstruction, the flow has been reconstructed with the mesh. We look at here, this 1 year's follow-up, 9 years follow-up, and recently the patient come back 23 years. Patient still present very well. The eyeball protrusions after the 23 years follow-up. And the other is transentrance. This approach usually cannot be used for the patient had a secondary case, especially the patient had a severe the scarring or the patient needed associated zygoma or ostomy in the secondary cases. I think this approach can minimize the growth manipulations eliminate the need for the lower lip incision. But definitely the reconstruction is more difficult for the implant placement. You need additional endoscopic entrance. Recently, I think the computer-assisted orbital reconstruction become more and more popular. This kind of the computer surgery allow use for the preoperative planning and allow you have a more precisely intraoperative navigations. And also you can use in intraoperative CT scan or 3D CM to provide the immediate visualization, provide additional information we will mention later. And it can be used for the postoperative quality control. So even used widely for the tumor ablation, dental implant placement, TMJ reconstruction, scar-based surgery, or the other post-traumatic facial deformity corrections. Regarding the pre-surgical planning, we need to input the CT scan into the software for the data process. So we can analyze the virtuous model, then we can determine the extent of the defect, we can plan our surgical approach, and also the mirror the affected side into the affected side to look at what is the normal contour of the injury side. Then simulation the ideal result. Then also we can create the virtual model corresponding to the desired result for your exercise. CT scan provide you the preoperative. You can see the defect size on the coronal view and also the sagittal view. So you can decide your implant size preoperative. Then we can do the pre-surgical examination. If the patient have the left side, the endosomas, we can look at the mirror image, look at the difference between the ideal position and the injury the side. Also, the major difference of the endosomas on the left side of globe. Then during the surgery, we need the registration for navigation. We also put on the dynamic frame, reference frame on the scalp. For the brain lab, that usually using the service, the registrations for detect the image on the navigation system. They using the 3 infrared such as this to the point, so they can control the patient position with point. For this patient application, with the patient presenters have left side endosomas. Obvious, we can see the patient left side endosomas on the one-eye view. During the setup, we look at the navigation system. We set up then check the positions. And in this case, we combine with the endoscopic flow, remove the bone graft, and then we check the positions after placement of the maple implant, check the positions, what we need, the positions. Then this immediate postoperative, only the 2 weeks later, we can see the patient have a very symmetry eyeball position, a little bit exosomas because this CT scan was followed up only 1 month later. For the medial wall fracture, this patient had the left side medial wall fractures, is all fractures. So we can see the patient had the subtasa hollowing. CT scan can see the really severe endosomas due to the unrepaired medial walls. So using the navigation system, we can approach that to confirm the position of the eyeball during the surgery and after reconstruction. So this the eyeball position will confirm to the position we need. So this is already 3 months after. We can see really patient had a symmetry eyeball projections. The other case can combine using the other medial wall fractures for the right side medial wall fractures, and we combine with transnasal. So this patient will using the Stryker's system, the restoration using the framework adheres to the face, and then we can transnasal approach. And under endoscopic view, we can visualize where we need to reconstruction, and then after reconstruction, with the medial wall, we can check the position of the main plan at a good correct position. This is immediate the result during operations. And also recently we using this method combined endoscope for the orbital roof fractures. You know, in the past we always using the coronal incision to approach the roof, but now under the two system navigation and endoscope, we can use a small incision such as the supratarsal incision or the brown incision to approach the roof easily without a very big incision. This case example present to us have the left side hypoglobus. We can see that the patient has symmetry the eyeball position. That's because the patient had reconstructed the graft on the roof. So push the globe downward and the inadequate flow reconstruction and also the medial wall. So with these methods, we remove the previous graft carefully without damage into the scar base or the orbital roof. So we can check the position what we need to reconstruction the area on the orbital roof. And then also we need to reconstruction the flow with the implant. We check the position so we can see the eyeball projections is better, and the eyeball position also more symmetries compared with preoperative conditions. And this is another very severe endosomas present to us, have a 7 millimeters endosomas. This patient is being treated outside the hospital at foreign country, but still gets such a severe endosomas. We measure the endosomas, the difference between the both eye around the 7 millimeter difference, and also has see the roof fractures, medial fracture, inadequate flow reconstructions. So reconstructing the left side orbital through subsidiary and supratarsal incisions. So this is the intraoperative view. We can see the previous fracture site here, but we need careful reconstruction. But we need to very carefully dissection and make sure the eyeball can be completely push upwards, so we can see all the scar tissue has been reduced. Then we check the position over the roof. This before and this is the afters, and for the medial wall and also the flow before and after. This is before surgery. This the after surgery. So we can see the postoperative the warm eye view. Can see very symmetry eyeball projections. And this pre and also the postoperative CT scan. We look at the difference between before and after surgery. Another example, the patient has also the all fractures have a very severe endosomas. And we look at the CT scan, I can show that the flow fractures and orbital roof fracture too. This is a huge defect. Above is the scar base. This brain tissue can be seen under the endoscopic view. We can see that the pre and postoperative result. This postoperative result, the flow has been reconstruction and the roof has been reconstructed well. So we can combine the minimal invasive method endoscope navigation for the primary and secondary the orbital reconstruction. We include 24 patients. Most patients present had endosomas, diplopia, and every time operation like actually it is more than 1.5 years. So most of the cases was late reconstructions. So the result, we using the CT scan to evaluate postoperative result. You can see there is no residual endosomas, but patients still have a residual diplopia, but most of them improve. No patient had hypoglobus. And look at the patient presenters had preoperative more than 2 millimeter endosomas. This average is 3, postoperative 0.3 millimeters. For the patient preoperative endosoma, 2 millimeters, postoperative 0.06. So early surgery can get the good result. Late surgery, preoperative 2.6 millimeters, also get the good result too. The others, the patient early 1 month, we can look at the orbital volume, the difference. Secondary or late, they have affected orbital is more increased, but postoperative, both orbital volume was almost the same. So before and after, there's a significant improvement. And then we want to increase into the intraoperative accuracy. So we developed the intraoperative imaging. This intraoperative imaging can allow our surgeon have immediate detection and correction in complete operations. So you can supply more additional relevant information, can improve the clinical outcome. So it can be indicate the cases, especially for the secondary craniofacial reconstructions. For you assess patients, visual have a difficulty to make the exposure. That is our indication for that. Intraoperative second first have been used for the neurosurgery, but have been proposed by the Dr. Stanley in 1999. He used that for the orbital ligament fractures, and first also used that the tool for the orbital reconstruction too. This is a previous CT scan, it's more bigger, and there the time for scanning longer, 30 to 40 minutes. These need the CT scan gantry tilting 25 to 30 degrees. Nowadays, it's not necessary to need. This is already the method using the seroton. The scanning time only 3.5 minutes. The only indication we need the radiologist the help to set up all the scanning machine. After that, we can see the immediate results, but we also need the radiolucent horseshoes to prevent the scanning. For the sub safety is usually safe for the radiations. For this case, it had presented as a secondary orbital reconstruction because the right side endosomas and due to the previous inadequate reconstruction of the medial wall and also the floor. So using the method endoscope approach, we can identify the defect and immediate intraoperative scan. We can define our the implant positions. And we found that one of the implant has inadequate the placement, so we can readjustment immediate. So this is the pre and also the postoperative result. We can see much improvement of the eyeball projections. The other case to present us had because the left side old orbital fractures and the digomic deformity. So this is the intraoperative CT scan viewing, symmetry eyeball projection, and for the malar projection, we're using the implant for the symmetric malar projections because the patient don't want to have the zygoma or sodomy, so we're using the implant. So immediately we can look at the CT scan to see our reconstruction is adequate or inadequate. So you can see that preoperative patient had a hypoglobus endosomas, and postoperative result patient have a very symmetry the eyeball projection, and also the mana projections. This immediate, this possibly CT scan, you can look at the mana implant has been placement in this way. We have used that the tool for evaluating patients. Regarding the overall volume, we can see preoperating the fracture size 26.5 millimeters, intraoperative 22, and postoperative 21.6. That means we a little bit adjustment the overall volume after immediate intraoperative the CT scan. Except the intraoperative scan, also you can use in the other 3D CM to have less radiations, and you can set up this intraoperative 3D scan by yourself. This is the example we can see. The scanning time is less. Usually the scanning time only the 1 minute, but you need the several minutes to set up the intraoperative 3D CM to scanning. Then after that, you can look at your implant positions. You can see the implant has been well produced or not. But the difficulty for this intraoperative 3D CM is it's hard to visualize the radiolucent implants such as the maple. And then nowadays there has the O1 using for the intraoperative image, but definitely this device is more expensive than the intraoperative 3D CM. And Preoperative also developed a kind of the instrument. They're using the portable CT integrated with navigation, so you can immediate the scan the patient, put all the image, and fuse into your navigation system to check your planning with immediate CM and to check the real position, so you can readjust the improper position of the implant. So we compare the intraoperative image. We found the navigation can be used more frequently for real time. No radiation, no implant, but the difficulty is implant invisible. But it can confirm the soft tissue augmentation. Price less cheaper compared with intraoperative scan. Usually we use it for the only 1 or 2 times. But you can see some implant, especially like the maple, you can confirm the soft tissue augmentation, but price more expensive. Compared with intraoperative 3D CM, they can be used for the several times, but had less radiations, price cheaper than the other navigation or intraoperative CT scan. And nowadays, I think the PSI has been widely used for the craniofacial reconstruction. This is a paper being published in 2015. They using the preoperative CT scan to visualize the defect area. Then they start to design the proposed implant size with the CT scan. After they design the defect size, they can export into the STL file, and the STL file can made with the 3D printing implant in this appearance. So you can combine the 3D implant PSI with navigation system during the surgery, confirm the position of the adequate reconstruction over the medial wall and also the floor. And we can also find the PSI has been widely used in recent. This being, you can see from the midline in just 2010, only 20 papers has been published, but 10 years later, we can see that more than 100 paper has been published using the PSI. Doesn't mean PSI has been widely used and much more accepted by the craniofacial surgeons for the craniofacial reconstruction. So in summary, our talk, I think that for the orbital reconstruction, I think carefully preoperative examination combined with ophthalmic consultations is also important. Preoperative CT scan almost become the routine survey for any kind of the orbital the injury. We can choose a proper graft regarding the autogenous or the meta or the other alloplastic implant. Really depend on the surgeon preference and also the patient choice. We can actually using the own method to adapt minimal invasive methods such as endoscope to minimize and conceal all the surgical scar. Cavity-assisted surgery nowadays is offered a more surgeon confidence, safety, and reliability, and also you can have a very good predictable the outcome. This is our reference. I'd like to thank you all of you for the kind attention. Thank you.
Okay, thank you very much, Professor C.T. Chen. I think I collected some of the questions from our audience already, but I have to say thank you for your professional sharing, not only in clinically, but also a lot of paper publishing with us. Okay, the first question is that, Professor Chen, thank you for your sharing. I want to ask, how can you protect the orbital component during drill the screw via transnasal approach? Thank you.
Oh, okay. Transnasal approach, usually we do not use the screw. We only dissect the ethmoid sinus and identify the fracture site. Then we using the maple or the Gore-Tex implant put inside the orbital. So we no need for further fixation. Or we only fixation that using the kind of the nasal pore or mirror cell for temporary external fixation inside the nasal cavity. So we don't need any kind of the drill for fixations.
Okay. And the next question is hypotensive anesthesia always needed for the endoscopic approach?
Yeah, I think it's for the all kind of the endoscope surgery, because our incision is quite small, so we need the hypotensive anesthesia, just like we did for the osteotomy surgery. We need a hypotensive surgery, so we need the cooperation with our anesthesiologist.
Okay. For the enosomus, do we do anatomical repair or overcorrection? Any method we can evaluate during the surgery?
Okay. I think there's really a difference for the primary. The orbital fractures, we need just only the anatomic reconstruction. So we can use any kind of a titanium mesh, bone graft, or the others like a maple implant for bridging the defect. But secondary reconstruction of the orbit to correct endosomas will be another story. We frequently found the anatomical reconstruction is not adequate to correct the endosomas. So definitely we need additional graft, such as the maple or the bone graft to augment the tissues. Very interesting in our previous study, especially we have an intraoperative CT scan. We found that the patient had intraoperative 2 millimeters. We found the postoperative result or long term. So the surgeons, you need to reconstructing for the orbital defect, especially for the secondary correction of the endosomas. I will propose around the 2 millimeter exosomas would be necessary to maintain the symmetry hypoperturbation in the long-term follow-up. But how do we evaluate that the patient had a 2 millimeter astomas? I think there's only right now accurate evaluation only one way. One is navigation system. So preoperatively we can simulate the normal globe positions into the injury globe. So we can see the what is where is the correct position of the globe. We need the reconstruction, and then during the intraoperation, we need to correct overcorrection 2 millimeter compare the position we want to correct. So that will be our ideal position, the position of the globe position for further reconstruction. The others, if do not have, you really do not have the navigation during intraoperative, you might be using the like a NAGO, the exothermometer or the others. You can evaluate the intraoperative. But you need to definitely need to sterilize your instrument using for the intraoperative use.
Okay. Thank you, Professor. The next question is how do you make selections for implant material, especially autologous bone graft or other alloplastic graft? Please.
As I mentioned about actually, I will right now I will let the patient choose the autogenous or the alloplastic implant. So the patient can choose what kind of implant they need. What's the advantage or disadvantage implant they need. We need to explain to the patients. So the patient decide. Once the patient decide, so we can explain what we need to use in the regraft or the covering bone graft. We need to explain to the patient. But if the patients want to select the alloplastic implant, no, the most commonly used will be titanium mesh and maple implant. But if in the secondary cases, especially for the secondary reconstructions for endosomas or reconstruction, I think that the reconstruction with titanium mesh cannot augment the orbital volume. So we always tell the patient they need the maple implant for the orbital volume augmentation. So there's the audience asks about the experience of dice cartilage, cross cartilage. Definitely, you can use the dice cartilage, I think, for the volume augmentations. But you need to basically you need a kind of the like the titanium mesh to make the base. Then using the dice cartilage for augmentations. I think one of the Professor Dr. Jingwei Li has had such kind of experience and also published in the JPROS.
Okay, thank you, Professor. The next question is how do we measure the endosomas clinically in millimeters? What is your instrument? Yes.
As I mentioned, we're using there has a true exothermometer. As I mentioned, one is the NAGO. The NAGO, I think these two the exothermometer has been widely used in the ophthalmologists, so you can use that for clinical evaluations. Okay,
and the further two question is almost the same. The audience want to know how frequently the oculocardiac reflex happen during the surgery, and how often you have the patient with the blindness because of a maxillofacial fracture. Thank you.
How often you have a oculocardiac reflex? I think that's depend on your dissections. If you really push the globe, more intense or more posterior, definitely you can have the oculocardiac reflex. So you have to hear I will suggest all the craniofacial surgeon need to hear the EKG sound, not the sound for the music. I always abandon the kind of the music. So you need to you need to listen to the EKG sound very carefully. You hear the sound is become very slow, you might have an ocular cardiac reflex. So you need to release the globe retention immediately to release to relieve the ocular cardiac reflex. But regarding the optic nerve injury in the maxillofacial trauma, right?
Yes, yes. Yeah.
I think the incidence, our previous study may be still less than 3 or 4%. It's not really frequent, but most frequent with associated craniofacial injury, cranial injury.
Mm-hmm. Okay. And for pediatric, the orbital floor fractures, and what implant material you prefer to use?
Theoretically, I would suggest the autogenous because we still not know what is long-term result using the Alloplastic implant as like a titanium mesh. We really don't know. We do not have a very long-term follow-up. But so I would like to suggest all the craniofacial using the regraft or the other cavern bone graft if they need a coronal incision. I should like to use the autogenous graft for pediatric patients.
Mm-hmm. Okay, the next question is from Soyeon from Korea. Thank you, Professor. I want to ask you any surgical tips to prevent post-surgery ectropion. The skin muscle flap is still critical, but rarely we encounter difficult post-op ectropion. So what is your tip to prevent the post-surgery ectropion? Yes.
Okay, for subsidiary incisions, yeah, I think for the experienced surgeons, especially for the experienced surgeon, you may not have the long-term the complication such as the ectropion, but you might have a short terms. So I think I have my resident or sometimes a fellow dissect using the subsidiary incision. I found that almost all of them have the postoperative ectropion after subsidiary incisions. I think the dissection is because they need the too much injury to the ocular muscle. I would suggest using the scalpel to do the some sharp dissections. But for the old patients, such as the patient more than 60 or 70 years old, the muscle had a lack of the less muscle tone. So you can expect the patient will have a high incidence the postoperative ectropion. So for that kind of patient, I would suggest you might do the transcontinental incisions plus a lateral consotomy to prevent further the postoperative ectropion. So I think the recent 10 years, I might already change my traditional subsidiary incision into the transcontinental incision with lateral consotomy. It's much dependent on you need more extensive dissection or not.
Okay, thank you, Professor. And two more questions. The question is from Cambodia. He want to know about the 3D biomodel can help for nasal endoscope approach or using the KCAM design. Which one is better for the nasal endoscope approach? 3D biomodel in the KCAM.
3D model that only let you know where is the lesion, where is the defect, but cannot help your the intraoperative dissections. KCAM, and also that's kind of the preoperative design. So only way only way that I think that can help you to identify intranasal structures and also identify the defect through the transnasal. I think you can using the navigation probably the best tool right now.
Mm-hmm. Okay, the final question is that what determined the posterior extent of your inserted titanium mesh in orbital floor fractures?
That means you need to identify. You need to identify so-called posterior ledge. But sometimes in the very severe orbital trauma, you really cannot identify posterior ledge. So it really depends on if you still can identify the posterior ledge, you can put on any kind of implant you got or the other autogenous bone graft put on above the posterior ledge. But if you cannot define the posterior ledge in very severe the orbital trauma, you might using the mesh, and you always need to know the position of the posterior ledge from anterior to posterior. Always is like the S shape from anterior posterior is already the 45 degree upward inclinations. So you need to put the implant a little bit more upwards, then gently fix your implant at the anterior orbital ring.
Okay, thank you, Professor C.T. Chen. Any question from the audience want to ask Professor C.T.? Okay, okay, okay. Okay, we have the final one. Okay, the last one, okay. Thank you, Professor. I would like to ask you about comparative outcome between the temporalis fascia flap and the MAP-POR in the reconstruction of orbital floor fracture.
Okay, I really cannot imagine why we should need the temporal fascia flap. That means you need some kind of the soft tissue for augmentations. But I think the temporal fascias have been used for that, like for the lip augmentations. So yeah, maybe definitely you can use in the kind of the temporal fascias for I think for the reconstruction. You can use that, but still you need to harvest the temporal fascia through the scalp incisions. I really don't think that will be more convenient compared with the others, the alloplastic implant. Nowadays, I know the more young surgeons like to use in the alloplastic implant. They try to save the operation time in the operating theater. I think the harvest kind of fascia is not a typical problem. Yeah.
Okay. Okay, thank you, professors. I think we can have the little time to have a group photo together and to memorize the very valuable moment, okay? So please show your smile and turn on your screen with us. And I would like to take the screen Photoshop. Oh, everybody is awake. Oh, so nice. Okay, yeah. We are so happy we have at most 140 audience today with so probably we have a 5-page of audience now. So allow me to have a 5-time capture with all of you. And in the first page, okay, please, I will count to 3 and you can say cheese to me. Okay, 1, 2, cheese. Thank you. And I have to go to the second page. Let's go to the second page. Okay. 1, 2, cheese. Thank you. If you are not know which page you just always keep a smile. Okay. Thank you very much. And I will go into the third page. And 1, 2, cheese. Okay. Okay. And I'm going to the Next one. 1, 2, cheese. Thank you. And then the final one. Okay. Thank you very much for your cooperation. 1, 2, cheese. Okay, very good. Okay. I have to say one more time thank you and pay my most gratitude for our special speaker, our Professor C.T. Chen today. Very comprehensive and very educational lecture, not only for the resident online, even all the very experienced surgeon as well. We all learned a lot from all of you. Thank you again. And I saw a lot of friends, not only from Japan, from Korea, from Hong Kong, and from Myanmar, from Cambodia. Thank you for all your long-time support for ICC. Next month, October, we prepare some of the topic related to OGS. Not a simple OGS. The topic is related to the secondary and the revision of OGS. How could the expert to teach us to deal with that kind of difficult cases? So always welcome for your participation. And thank you again. Good day and good night. See you. Bye-bye.